Hi, good afternoon, everyone. Welcome to B.B.S, Stroke Prevention, Recognition, and Treatment. Thank you for joining us this beautiful spring day. My name is Eleni Anzelatis. I'm from the Community Health and Wellness Department at Suburban Hospital. Today we have Dr. Malik Adil and Ms. Victoria May from our stroke team, stroke program. May is in honor of May is Stroke Awareness Month, so it was very important that we have this presentation for you today. Before we begin, I just want to go through a few housekeeping items. The first being is that the seminar is being recorded, and we'll make sure that the link is available to you in the coming days. Secondly, please hold your questions until the end. If you have a question, please feel free to use the Q&A box that's on the bottom of the screen. And lastly, we have an evaluation. When the webinar is over, a link will pop up, and you'll have an opportunity to click the link and then complete the evaluation. So we really like to hear your feedback, what you learned from today's presentation, what you would like to hear more of, any possible topics for the future. We really value your feedback. Okay, so without further ado, I will introduce Dr. Malik Adil and Ms. Victoria May. Again, they're from our stroke program today. And thank you again both for being here this afternoon, and we'll get started. Thank you again.
Thanks, Eleni. Good afternoon, everyone. I'm Victoria May. I'm the stroke program manager here at Suburban Hospital. And as Eleni said, we're here to talk to you about stroke prevention, stroke recognition of signs and symptoms, and treatment options. So just here's sort of our basic agenda for this afternoon. We're going to talk about stroke basics, sort of what is a stroke, different types of stroke, common causes of stroke, stroke signs and symptoms. We're really going to drill down on that. What treatments are available if you or a loved one is experiencing a stroke, what to expect if you unfortunately experience a stroke and end up in the hospital, sort of what to expect while you're in the hospital, what tests will we be running, what things we'll be looking for, ways to reduce your risk of experiencing a stroke, and lastly, our B.B.S acronym to help you remember the stroke signs and symptoms. So at this point, I'm going to turn it over. Actually, I'm sorry, it's me again. So just some stroke basics for you all. So in the US, every 3.5 minutes, someone dies from stroke, be it immediately after the stroke or from complications related to the stroke. It's the 5th leading cause of death in the United States currently, and it's the leading cause of long-term disability in the United States. And this is because billions of brain cells can be lost in a matter of a few hours when someone's experiencing a stroke. For a stroke that occurs in a major blood vessel of the brain that supplies a large portion of brain tissue, 32,000 brain cells die per second, 1.9 million per minute, and 120 million per hour. And it's been estimated that if a large stroke goes untreated, up to 1.2 billion brain cells are lost in the sort of immediate post-stroke period, which roughly is the rough equivalence of 36 years of accelerated brain aging. So it's really important to, when you recognize stroke symptoms, to act on them. It's a medical emergency, and to act on them quickly so that we can intervene to prevent this massive loss of brain tissue. On the good note, though, US stroke incident rates fell by 32% between 1995 and 2012, largely due to improved management of cardiovascular risk factors. Because at its core, stroke is a cardiovascular disease. It's not necessarily a disease of the brain. The brain's impacted by it, but largely it's due to diseases of the blood vessels. So cardiovascular risk factors that we've been very good at improving our treatment of is lowering cholesterol, getting better blood pressure treatment to reduce the risk of atherosclerosis development, which we'll talk about a little bit later. At this point, but however, worldwide stroke incidents have increased 70% in the same time period. And this is largely in lower income and lower middle income countries. A lot of it has to do with they're starting to get the diseases of the developed world with, poorer diets and less activity and things like that. So they're kind of behind the curve where we were, and hopefully we'll get better at stroke prevention in that group as well. So at this point, I'm going to turn it over to Dr. Adil to talk about what is a stroke.
Thank you, Victoria, and good afternoon, everyone. So stroke is a disease that affects the arteries coming to the brain or within the brain. It is an emergency. As Victoria was telling, that stroke is the 5th leading cause of death and the leading cause of disability in the United States. So a stroke occurs when blood flow to the brain is stopped. The brain needs a constant supply of oxygen and nutrients in order to work well. If blood supply is stopped, even for a short time, this can cause problems. Brain cells begin to die after just a few minutes without oxygen and without the blood, as Victoria was saying, 1.9 billion cells in a very short period of time. And when brain cell die, brain function is lost. One may not be able to do things that are controlled by that part of the body. And stroke, there are 2 types of stroke. One is called ischemic stroke, and the other is hemorrhagic stroke. Ischemic stroke is a common one, and the stroke caused by a clot obstructing the flow of blood to the brain is called ischemic stroke, and the stroke caused by blood vessel rupturing and preventing blood flow to the brain called a hemorrhagic stroke. And then next slide. So with that, there are 2 types of a stroke. One is ischemic and hemorrhagic, but based on the mechanism, or I would say the mode of action, there are 2 types. One is embolic and one thrombotic. And the easier way of understanding is that if the stroke or the clot is coming from the artery and it's developing within the artery, it's thrombotic. But if it is coming from somewhere else, for example, from the heart, then it's called embolic. So anything within the artery, within the vessel, developing within the artery, and that clot comes to the brain and obstruct the flow, that is a thrombotic event. And embolic is that's coming from away from the arteries, for example, the heart. And there are many common causes of stroke. One of the causes is atrial fibrillation, which is an abnormal heart rhythm. So usually the heart function is very synchronous. It beats very synchronously. But because of abnormal heart rhythm, if heart beating is no more synchronous, then it forms a small parts in the ventricles in the heart. And then when the heart pulse, the clot arrives in the brain and can cause a stroke because of the obstruction of that vessel. The other cause is high blood pressure, which is very common. And then this high blood pressure can make a number of changes in the blood vessel over the period of time. It's one of the common cause, a leading cause of a hemorrhagic stroke when there's a very high blood pressure and the vessel rupture that causes a hemorrhagic stroke. But also, if there's a hypertension, if there's a high blood pressure for a longer period of time, 10 years, 15 years, 20 years, and uncontrolled, that can cause a lot of changes in the brain vessels and can contribute to ischemic stroke also. The other is atherosclerosis, which is deposition of a cholesterol plaque. Again, this is over the period of time. This is started at the age of 20-25. If you're not doing exercise, if you're not eating healthy, all these factors contributes, and then that plaque grows over the period of time and can sometime detach and arrives in the brain and can cause a stroke. So in short, stroke is a disease that affects the arteries in the brain. It's 2 types. One is ischemic stroke, which is because of the blockage. The other is hemorrhagic stroke, which is because of the rupture. And the most common cause is hypertension and atrial fibrillation. Next slide.
Okay, so the next 2 slides are illustrations of how atrial fibrillation can lead to an ischemic stroke, and also how atherosclerosis can lead to a stroke. So the first one discuss atrial fibrillation.
Atrial fibrillation, or AFib, is the most common abnormal heart rhythm. In a normal heart, the 4 chambers of the heart beat in a steady rhythmic pattern. With AFib, the atria fibrillate and create an irregular rhythm. In AFib, the heart works less effectively as a pump, resulting in an area of the heart where the blood flow is slow or stagnant. When this happens, a blood clot can form, and it is this that accounts for the increased risk of stroke. The problem with the blood clot in the heart is that some or all of it can break away and travel along our arterial highway directly into the brain. At some stage, as the blood vessels branch and become ever finer, the clot, or fragment of the clot, is going to be too large to progress any further and will block the vessel in which it is traveling. This means the surrounding area of the brain can no longer receive oxygen delivered by the blood, causing the nerve cell to stop working. This complication is called stroke. Early detection of AFib, followed by adequate treatment, can reduce risk of stroke by 68%. Sometimes people with AFib have no symptoms. Still, others may experience rapid and irregular heartbeat, dizziness, chest pain, palpitations, and so on. Atrial fibrillation leads to a 5-fold higher risk of stroke. This makes identifying and treating AFib so important.
Okay, so that one described atrial fibrillation. And this next video describes what causes arterial atherosclerosis, which can lead to blood clots.
The progression of atherosclerosis begins when the endothelial cells of the arterial wall become damaged. This can be caused by hypertension, smoking, hyperglycemia, and hypercholesterolemia, which is an increased number of LDLs in the blood. Endothelial cell damage increases the permeability of the arterial wall, allowing LDLs to enter the tunica intima. White blood cells, such as monocytes, normally move freely through the blood vessels and do not attach to endothelial cells as they stream past. However, when endothelial cells are exposed to irritating stimuli or damage, they will express adhesion molecules that can capture nearby white blood cells. These white blood cells undergo morphological changes that allow them to flatten and squeeze between endothelial cells. This movement of white blood cells out of the bloodstream is called diapedesis. White blood cells are capable of producing free radicals, and when these free radicals come in contact with LDLs, oxidation occurs. Oxidized LDL particles are especially effective at attracting and activating white blood cells. White blood cells then engulf the modified LDL particles, which stimulates them to produce even more oxygen-free radicals. It becomes easy to imagine that an area of endothelial damage will lead to an accumulation of modified LDL particles and migrating white blood cells. A positive feedback situation begins to arise when accumulating immune cells and modified LDLs bring in even more immune cells and modified LDLs. Macrophages in the tunica intima start to engulf modified LDL particles. Ultimately, this leads to the production of a cell called a foam cell. A foam cell is saturated with LDL particles, and the excessive amount of lipid in the cell gives the cytoplasm a foamy appearance. Foam cells ultimately die and release their contents, which are then quickly engulfed by other nearby white blood cells. Please note that the animation shows smooth muscle cells, also engulfing LDL cholesterol. Eventually, the accumulating lipid from the processes just described and the fragments of dead cells produce an area with the lipid core that begins to form a plaque. Endothelial cells cover the plaque. The plaque accumulates calcium salts and more dead cells over time, and it will harden. This plaque in the arterial wall is atherosclerosis. If the endothelial cells over the plaque are compromised, blood clots can form on the vessel wall. Remember that healthy endothelial cells normally express inhibitors of clotting, but now since they are damaged, they no longer do this. Over time, ruptured areas of plaque may create a situation where an area of plaque may jut out into the vessel lumen. A clot that forms and attaches to the wall is called a thrombus. If the clot breaks loose from the arterial wall and floats downstream to even smaller vessels, it is called an embolus.
Okay. Dr. Adil, back to you. You're on mute, Dr. Adil.
Sorry about that. So I think we already discussed about hemorrhagic strokes. Again, as I was mentioning previously, that the two types of stroke, the ischemic stroke and hemorrhagic stroke, the blockage of the vessel is ischemic stroke, and when there's a rupture of the vessel and then blood accumulates within the brain is hemorrhagic stroke. And it's less common. The ischemic stroke is around 85 to 87%, and then 15 to 13% is hemorrhagic stroke. Now, there are a number of causes, as we discussed, regarding ischemic stroke. So the most common cause or the risk factor that puts you on a risk of having a hemorrhagic stroke is hypertension. There are other causes like a small outpouching, which we say aneurysm, or any other vascular, like the arteries or veins abnormality. It can be congenital, it can be acquired. I'm not going to go into detail, but I think for the audience today, the most important thing here to remember is that it's a different type of a stroke, and it's very important to identify whether it's ischemic stroke or hemorrhagic stroke, because the treatment is different. And the most common cause or the risk factor for hemorrhagic stroke is hypertension. Next, please. Okay, so TIA, transient ischemic attack. So a lot of time you will hear another term interchangeably called mini stroke. It's the same thing. Mini stroke is TIA. And then a TIA is a brief interruption of a blood flow to part of the brain, which may cause temporary stroke-like symptoms, but does not damage brain cells or cause permanent disability. So stroke is something when there is obstruction and the obstruction stays there, and there is obstruction to the blood for a longer period of time to the point when the damage you can see on the imaging and then causes a disability. So TIA is a very brief time. It's an interruption, but it's for a very brief, small moment where the clot comes and goes away. And then the symptoms, you will notice the symptoms for 10, 15, 20 minutes. And usually these symptoms resolve within 24 hours and does not damage a brain cell and cause a permanent disability. Now, TIA are often an early warning sign that a person is at risk of stroke. About one in third people who has a TIA goes on to experience a subsequent stroke. The risk of a stroke is especially higher within first 48 hours after a TIA. So early intervention to reduce the risk factors are vital. Next slide. Now, this is one of the very important part. I'm going to spend a little bit of time. So the sign and symptoms of stroke. I think it's the hardest part of recognition, because once you recognize, as soon as you recognize, everything starts from here. Now, this table, I'm sorry for the busy slide, but it describes the symptoms in two ways: that the symptoms that patient observe him or herself, and then a family member or a loved one can observe symptoms and can activate the pathway or call 911. So the symptoms are pretty straightforward. There are two types of areas in the brain. One is eloquent areas, one are non-eloquent areas. The eloquent areas are where, when there is a damage, you will see dysfunction or symptoms according to that area, because that area of the brain is not getting a blood supply. Sometimes you can have a stroke which is a silent stroke, the areas that are not basically controlling any part of the body, or the very subtle symptoms which you can miss. So the common symptoms is a confusion, difficulty in understanding, trouble finding words, arm weakness, leg weakness, numbness, loss of vision in one eye or both eye, blurry vision, or any other loss of balance. Now, these are a lot of symptoms. So what American Heart Association and American Stroke Association did, they created a score initially called a FAST score, then they updated called B-FAST, and Victoria is gonna talk about. So instead of remembering all these symptoms that are mentioned in the busy slide, I would say that if you remember the B-FAST, that is a take-home message from this lecture also. B is for balance. E is for your eye symptoms. F is for your face, any weakness or numbness of the face. A is for your weakness or numbness of the arm. S is any speech problem, and T is time. So 70 to 80% of patients with stroke-like symptoms fall into this category, that you will see a one symptom from a B-FAST. So that's the easy way of recognizing a symptom. And as soon as you recognize, call 911. And then there are a couple of things that are important, that as soon as you recognize these symptoms, I mean, the patients and the family member both, that if you can memorize, or if you can try to figure out what is the last known normal, like at what time the patient was normal and in the usual state of health, and also what time is the symptom discovery, because we need these two times. And then the third thing is whether this patient is taking any blood thinners, like there's warfarin or Eliquis or any kind of a blood thinner. So this information is important for the emergency department to make a decision on certain treatment that we're going to talk about later in this presentation. But as soon as you recognize these symptoms, call 911, get this information. And also, I would like to emphasize a little bit why time is important, like why time is important. As Victoria was saying, that 1.9 billion cells dies in a short period of time. So time lost is a brain loss. Time is brain. On average, 1.9 million brain cells dies every minute that a stroke goes untreated. Now, one of the best treatment of stroke is a clot buster medication that you can only give within 4.5 hours. So that's why the timing is important. And I will go in a little bit in depth when we will talk about the emergent therapies regarding the stroke. So just remember that time lost is a brain loss. Time is brain. If you recognize symptoms of stroke, the first step is always to call 911. Next slide.
So you recognize the symptoms either in yourself or a loved one or someone that you're with, and you call 911. Sort of what to expect when you arrive in the emergency room. So, I want to stress, call 911. Don't try and drive the person in from yourself. Don't try and drive yourself if you're experiencing these symptoms. It's not safe for you. It's not safe for anyone else on the road if you're experiencing these symptoms. And by contacting EMS, it gets you to the emergency room quicker. They can give us a heads up as to we have a potential stroke patient coming in, so we can start activating all of our team and have everybody waiting for you when you come in. So what's going to happen when you present is you're going to get immediately evaluated by the emergency room physician, and they're going to consult the stroke neurologist, someone like Dr. Adil. They're going to do a focused stroke assessment. So they're not going to do a complete head to toe evaluation of every last thing that may be going on with you, but they're going to focus in on what types of symptoms are you presenting. And yes, we think this might be a stroke. No, we don't. They're also going to want to know when was the patient last seen normal? When were the symptoms discovered? Because that can, as Dr. Adil will talk about a little later, will impact what treatments are available to the patient if they are in fact having a stroke. You're going to get vital signs taken. You're going to get an IV put in. Blood work's going to be drawn. And then we're going to determine what is the most appropriate diagnostic imaging that we can conduct on you. Here at Suburban, we primarily use MRI to diagnose emergent stroke. And that's a little different than most hospitals. MRI has some very significant advantages over a plain head CT. On an MRI, the ischemic stroke can be diagnosed within minutes of onset, versus a CT would only be able to rule out whether or not this was a hemorrhagic stroke or some other type of brain issue, versus it's not, it's okay to treat the patient with TPA. So it doesn't tell us whether or not the patient had a stroke unless the stroke is over 6 hours old, which at that point it may be, it's well out of the treatment window for certain treatments. So we're going to try and make sure that you're safe to get it. We're going to do an MRI clearance. If you are not able to communicate to us if an MRI is safe for you, we are going to try and contact someone who would be able to answer those questions. If we can't get that answer, we're going to do an X-ray clearance to make sure that you're safe. You don't have any metal in your body that would preclude you from having an MRI. And you'll get immediately taken to MRI for a scan. And that scan can be done in about 12 minutes. And the stroke neurologist would be reviewing this images real time and making a determination as to, yes, this is a stroke, no, this isn't, or it's an ischemic stroke versus a hemorrhagic stroke, and make treatment decisions based on that. And at that point, I will hand it over back to Dr. Adil to discuss the treatment potential.
Thank you, Victoria, and thank you for emphasizing on imaging. I will just add one thing, which is a very unique to the Suburban Hospital. We've been doing for the last 17 years, and then now it's a standard of care. And there's only 3 or 4 hospitals in the country that does. And as I was mentioning, that the timing is important, right? So there is a concept called wake-up stroke or a unwitnessed stroke. Like you saw a grandmother in the morning at 8 a.m. You walk into the room and the grandmother was not talking or was weak on the right side. So we don't know the timing. So all these patients where the timing is unclear, we don't know the last known normal, or we don't know the symptom onset, like what time the stroke symptoms started. These are the patients that were excluded from the clinical trials. And then if they go to any other hospital, they're not going to treat because we don't have the timing and the risk of bleeding is very high. One of the advantages of MRI is that we can age the stroke. So we do a number of sequences, which we cannot do on CT because CT takes at least 6 to 8 hours to show up a stroke and early changes, whereas the MRIs, as Victoria was mentioning, that you can see stroke within 3 to 4 minutes or 5 minutes of symptom onset. So with MRI, we can age stroke. So we can tell that the stroke started 2 hours ago, or 4 hours ago, or 6 hours ago, or 24 hours ago, and we can treat those patients. Now, those patients are pretty decent number. If you look at the literature, 25 to 35% of patients present in the ED with unwitnessed stroke onset or a wake-up stroke where the timing is unclear, and if they go to other hospitals, they will not get a treatment. Now in 2018, there is a trial called Wake Up. It's a standard of care, but there's only a handful of hospitals there treating wake-up or unwitnessed stroke because the MRI needs a lot of resources, and not every hospital can manage to perform MRI on emergent basis because it takes more time. And then also you need specialized neurologists and radiologists to read that MRI in a timely fashion because time is brain. So at Suburban, we've been doing this for 17 hours, and then we treat these unwitnessed stroke onset and wake-up stroke, which is a great thing. Now, coming back to the emergent stroke treatment, there's 2 types of acute treatment, which is one is a clot buster medication and the other is called thrombectomy. So the TPA, tissue plasminogen activator, is a clot buster medication, which we inject IV, and it basically, what it does, it just dissolves the clot. And then if the patient presents within 4.5 hours of last known normal, we can give this medicine. But if these patients, I'm sorry, if these patients comes after 4.5 hours, then the damage has been done, and the brain tissue is so fragile that if you push this medicine, the risk of having a bleed in the brain is very high. So that's why the time is key. Time is very important. 4.5 hours is a benchmark. And anyone who comes to the ED within this window can get an IV TPA. The other treatment is thrombectomy. In easy word, what we do is we pull the clot from the brain, like mechanically we pull the clot. So we go from the groin, one artery all the way in the brain. And if there is a clot sitting in the brain that's obstructing, if it is a decent size, we can pull that clot. Like if 10-15 years ago we were not doing this treatment, I would say like 5 years ago we were doing this handful of patients. Now the patients who are last normal within 24 hours, a lot of patients are eligible, and then we are doing a lot of treatment. So after 2018, this thrombectomy procedure is widely used in the country, and then the procedure that we were doing like 5-10 years ago was just few hundred, and now it's like thousands. So that's another emerging therapy. So two treatments. One is TPA, is a clot buster medication, give IV, it dissolves the clot. The second is if the clot is bigger enough in and obstructing a bigger vessel in the brain, you can go and pull that out. And over to Victoria.
So you come in, you've been diagnosed with a stroke. Depending on whether or not you receive treatment, that sort of dictates where you end up being admitted to within the hospital. Definitely, if you receive TPA and or undergo a thrombectomy, you'll be admitted to the intensive care unit for a minimum of 24 hours. And in the intensive care unit, the care will be managed by the intensivist in collaboration with the stroke neurologist. And you'll have frequent vital signs and neurologic assessments to monitor for complications, because TPA, one of the risks of that is a bleed. And also with thrombectomy, there is a risk of the ischemic stroke converting into a hemorrhagic stroke. And so we'll be monitoring you to make sure that you're improving or not having any kind of neurologic worsening. If you don't undergo a TPA or a thrombectomy and you're otherwise stable, no blood pressure issues or breathing issues or something like that, you'll be admitted to our intermediate care unit. And in the intermediate care unit, the care will be managed again by the intensivist in collaboration with the stroke neurologist. You'll have frequent vital signs and neurologic assessments, not quite with the same level of intensity as in the intensive care unit, and also undergo continuous cardiac monitoring, which would occur in the ICU as well. One of the things for the cardiac monitoring purpose is we're trying to see if there's that underlying atrial fibrillation that Dr. Adil described earlier. So the main focus of the admission after the stroke treatment is to understand why did you have a stroke, sort of the getting to why. So as I mentioned, we'd be doing cardiac monitoring to detect an underlying irregular heart rhythm, most likely atrial fibrillation. You'll undergo an echocardiogram to detect if there are any heart structure or functional abnormalities. Is there some sort of dilation of the heart tissue? Is a heart muscle not pumping effectively? These are all things that can lead to that clot formation in the heart that we saw on the illustration. We'll be doing vital signs to detect if you have underlying high blood pressure that may have not been diagnosed or was not being controlled well under a medication regime. And then we'll be adjusting medications and prescribing medications as necessary and monitoring response to those medications to see about getting to try and get your blood pressure under control. We're doing blood work as well to detect for high cholesterol. Do you have undiagnosed diabetes, or are you pre-diabetic? Do you have some clotting disorder? So if there's no sort of usual suspects identified, they might run some clotting disorder blood work as well. They'd also do a carotid ultrasound, which is just a non-invasive ultrasound of the blood vessels of your neck to see if there's any carotid artery stenosis or narrowing of the carotid artery that would possibly lead to a stroke, or any kind of dissection, which would be sort of a tear within that artery that could have a clot form and then break off and travel to the brain. You'll receive extensive education from your nurses and also from the neurologists and the doctors about your stroke, sort of the why we're doing the workup that we're doing, risk factors that you have, what to expect following your stroke as far as rehabilitation, and your risk factors and things you can do to help prevent you from undergoing a second stroke. You'll also be seen by three members of our rehabilitation team, a speech pathologist, a physical therapist, and an occupational therapist to determine what, if any, therapy services you require to help ameliorate any deficits that you have from your stroke. Speech is looking to see how safely you swallow. They're also seeing if you're having difficulty with aphasia or difficulty communicating, and they'll help initiate therapies to address that and give you strategies for addressing that. And the physical and occupational therapist will make recommendations regarding where they think it would be best for you to be discharged following the hospital. So the discharge planning process starts upon admission to the hospital. You'll be seen by a social worker who will start working on, will gather all the information from the rehabilitation specialists and the doctors to help make your discharge plan. And that may be hopefully just going home and resuming your life, but in many instances it involves potentially a short stay in an acute rehab hospital to do intensive therapy to help improve any stroke-related deficits. It may include being admitted to a subacute rehab if you don't have the ability to tolerate certain levels of therapy in a day, or it may unfortunately involve placement in a long-term care facility depending on the extent of the stroke. So how do you reduce your risk of stroke so that you don't have to go through any of this and you never have to be admitted to the hospital for a stroke? So the big thing is to achieve and maintain a normal blood pressure. It's been found that for every 10-point reduction in the systolic blood pressure, which is that top number, that reduces your risk of stroke. And so maintaining a top number level less than 130 was associated with a 42% lower incidence of stroke. So if you don't know if you have high blood pressure, get it checked. And if you do, see your doctor and get on some blood pressure medications, because the high blood pressure over a long period of time, as Dr. Adil mentioned, can lead to that atherosclerotic process, that hardening of the arteries and that narrowing of the arteries that can increase your risk of stroke. Some common blood pressure medications that are prescribed are metoprolol, otherwise known as Lopressor, lisinopril, otherwise known as Zestrel, carvedilol, Coreg, and amlodipine, which is Norvasc. And there are different types of blood pressure medications. They act in different ways. So even if you might not tolerate one particular type of blood pressure medication, there are other options that act in different ways that might be more tolerable. Get your LDL, or your bad cholesterol level, under control. So a 40% reduction in your LDL level is associated with a 20% reduction in your stroke risk. For primary stroke prevention, the target LDL level is based on your cardiovascular risk level. And this is something that your primary care physician, or if you see a cardiologist, can very easily, they have an algorithm they use to assess for cardiovascular risk levels. For secondary stroke prevention, so if you've already had experienced a stroke, we're going to be targeting an LDL level of less than 70. So this would involve prescription for a statin medication, atorvastatin, simvastatin, rosuvastatin, and what we tend to use is a high intensity statin therapy, because we want to be really aggressive about getting your LDL level less than 70. So it's very possible that you could be on a statin regimen in the 80 milligram range. And that's very common. This is, again, for secondary stroke prevention, when we're trying to be uber aggressive about our LDL reduction. If you're a diabetic or pre-diabetic, achieve and maintain normal blood glucose levels. As we saw in the illustration, high blood glucose levels lead to the atherosclerotic process. But the one good thing is that, or not good thing, but the interesting thing is that both intensive and poor glycemic control are associated with increased risk of stroke. So we're not looking for you to get your A1C at 4. If you have type 2 diabetes, you're looking to maintain an A1C between 6 and 7, and that's what you're associated with your lowest stroke risk. So we're not trying to drive your A1C down really low to non-diabetic ranges. I mean, if you can do it with just diet and exercise, great, but we're not trying to maintain a blood glucose level of 80 at all times. Lifestyle intervention. So these are the basic things that don't involve any kind of taking of medication. The biggest thing I can stress is if you smoke, stop. This includes vapes, e-cigarettes, chewing tobacco, any kind of tobacco, nicotine product. Please, please, please stop, because smoking is such a major contributor to atherosclerosis and stroke risk and all sorts of cardiovascular risks. Try to utilize a heart healthy diet that's low in fat, low in sodium, low in cholesterol, that's high in, that's primarily plant-based, not a lot of red meat or any kind of animal meat, animal products as far as meats are concerned. High in complex carbohydrates, low in refined carbohydrates, high in fiber. That can really help with your cholesterol levels. Regular exercise. We're not talking about going out and running a marathon. We're talking about going out and walking and just getting your 30 minutes of activity, 3 to 4 times a week. Achieve and maintain a healthy weight. If you're doing that heart healthy diet and you're getting the regular exercise, it's going to be easier for you to maintain a healthy weight. And stress reduction. I mean, obviously in this day and age, it's easier said than done, but just take a minute, at the beginning of the day, if you can, to just kind of find a zone where you're in a place of calm, or if you feel yourself getting stressed out, try and stop yourself. Biofeedback is a good way of sort of trying to address what your stressors are and then trying to come up with better ways of dealing with that. So, because the stress reduction, what they find is stress over time, long-term stress leads to inflammation, and that inflammation contributes to the atherosclerotic process. So I leave you with this, and again, Dr. Adil mentioned this. This is our acronym, B-FAST. So any sudden onset of a change in balance, so a loss of balance or dizziness, again, sudden onset is the key. A change in vision, you suddenly have blurred vision, can't see out of one side of field of vision, facial droop, you have a sudden uneven smile or slurred speech, arm weakness or leg weakness, especially if it's limited to one side of the body, or any kind of numbness that suddenly starts, any speech difficulty. You're suddenly having trouble articulating words, or you can't understand what's being said to you, or people don't understand what you're saying to them. What you're saying doesn't make any sense to them. It's time to call 911. So again, don't try and drive your loved one or yourself to the emergency room if you recognize any of these symptoms. Even if these symptoms sort of start, but then maybe resolve, again, it could be that TIA. And as Dr. Adil said, the TIA is a definite warning sign of a possible impending stroke. So we need to get to the bottom of what caused those symptoms. So be fast. And if you have any of these symptoms, call 911. So here are some additional resources, and I'll leave this slide up for people. We have lots of stroke information on Suburban and Johns Hopkins Medicine's website about the services we provide both here at Suburban and throughout the system. The American Stroke Association, stroke.org, their website's a wonderful, wonderful resource for patients and their loved ones about prevention, what to expect post-discharge as far as the rehabilitation process is concerned. The National Institutes of Neurological Disorders and Stroke at NIH, which we are a research partner of, they have really great patient resources. And strokeawareness.com, all great resources for more information about stroke and what to expect and how to care for a loved one, and also dealing with caregiver stress, because that can be hard to deal with someone with stroke. One last thing that I want to leave you with is stroke is both physiologically and psychologically damaging, and so it is not unusual for patients who undergo a stroke to suddenly have, well, not suddenly, but to start experiencing symptoms of depression for the first time in their lives. This is because for many, it's a completely out of left field diagnosis and life-changing diagnosis. And also physiologically, the brain has been damaged and it takes time for the brain to recover. So I would definitely urge, if you or a loved one experiences a stroke, be on the lookout for signs of depression and address those concerns with your doctor when you're following up, because there are treatments for it. And depression can make it difficult to participate in rehabilitation and try and get to your best place after your stroke. So that's my last plea. So remember, be fast, and hopefully we never see you in the hospital here with a stroke. But if we do, we will take good care of you. Over to you, Eleni.
Thank you, Victoria. Does anyone have any questions for Victoria? So if you do, please put them in the Q&A box. We do have one. I was answered, but Victoria, if you could just answer it one more time, that would be terrific. And Dr. Adil as well. How do you know which type of stroke your patient is having? Is there something we should be looking for in reporting symptoms to the doctor, or when you arrive to the emergency room?
So great question. I can take that question. So based on the symptoms, it's hard to differentiate whether it's a ischemic stroke, which is the blockage, or it's a hemorrhagic stroke, which is a rupture of the vessels. So that's why we say that do not drive, do not do anything, do not take any medication, call 911, they're going to bring it to the hospital. The only diagnostic way, the testing that we can differentiate between ischemic and hemorrhagic is imaging. CT scan or MRI will tell us. Now, there are some symptoms. For example, if you're having a bad headache, worst headache of life, that is more likely with the hemorrhagic stroke, right? If you have a sudden trouble finding word and all those symptoms, that can be with any of the stroke, with ischemic stroke or hemorrhagic stroke. High blood pressure, if you see very high blood pressure, we see that both in ischemic stroke or hemorrhagic stroke. So really, based on the symptom, it's nearly impossible to differentiate which type of a stroke. So you really have to come to the hospital and get the diagnosis whether it's ischemic stroke or hemorrhagic stroke, because the treatment is totally different.
Great, thank you. So we have two more questions. Symptoms, how severe? Many things can cause dizziness or loss of balance, for example. So how do you know if that's a stroke or anything else or something benign?
Yeah, very, very interesting question, very important question. I think so. It's challenging even for a neurologist. I mean, it's for us, it's challenging that this dizziness is just because of the stroke, or it can be because of a migraine, it can be because of your infection, it can be because of your low blood pressure, it can be because of your ear problem, it can be because of many other things. For one thing I would say that there are a couple of red flags that if you have that kind of a dizziness, you should prompt and call 911. Sudden onset, like really the sudden onset, all of a sudden sitting and you have a sudden onset. That's very important. With that dizziness, if you're having a vision problem also, like your eyes are moving and then you're feeling like you're on the boat, like very severe, that again, mostly this is more of a central, localized towards a brain. We call it a nystagmus. If you put your finger in front of your eyes and someone moves, your eyes will be moving like that, like oscillatory kind of a movement, right? So that's called nystagmus. So if you have eye symptoms, if you have a sudden bad dizziness, and in addition to that, if you have a risk factors, if you have a high blood pressure, if you're diabetic, if you have a history of a stroke, if you have a heart disease, right? Any of the risk factors with this sudden onset of dizziness and visual symptoms, I would say that definitely go to the hospital. But again, it's challenging until unless you do an imaging and see a stroke on the MRI.
So the moral of the story, I suppose, is if no matter what your symptom might be, if it's sudden onset, if dizziness, migraine, headache, you should just dial 911 so they can assess you.
Yes.
Okay. Yeah. Which leads me to this next question. So I'm part of Kaiser Medicare Advantage and live right near Suburban. Let's hope I stay healthy. Would I still call 911 if I detect any of the BFAST symptoms?
Yes,
Yes.
Oh, yes.
regardless of where you live, call
Regardless
911.
who your provider is, regardless which system you are, regardless who's covering your insurance.
That's a short answer. Yes. When do people typically develop AFib?
Oh, so again, so usually if you look at the literature, atrial fibrillation is you find in elder population over the age of 60 or 65. Very rare in the young population, a different heart disease in a young population, but atrial fibrillation is after the age of 65, 70, 75, 80, this age group. Now, when do you develop? Why do you develop? At this time, we don't understand that. There are some markers when you do an echocardiogram, which is the ultrasound of the heart. If you see the size of the chambers are not normal, they're bigger than normal, right? There are some structural changes that we see, and we think that the suspicion of atrial fibrillation is high. Then we go and recommend the cardiac monitoring. Now, the cardiac monitoring can be done in a different way. So, for example, when you come to the hospital, they attach you with a monitor. Monitors monitor your rhythm, and then you can see if it is an abnormal. When you go home, there is a called Holter monitoring. They can give you a device that you keep closer to your chest, just hang it in your neck, and that will monitor your heart rate. There's a small device that you can put under the skin that stays there for a number of years, and that can monitor your heart rhythm. So the answer is that it's usually in the elderly population, less common in the younger population. It's hard to tell when are you going to develop and how and all the mechanisms we don't understand, but the monitoring is the key.
Yeah, so following up with on what Dr. Adil said, if you have, like it was in the video, if you're having this racing heart rhythm, if you feel your heart racing and fluttering, or sudden dizziness and things like that occur, you definitely should go to your primary care physician, at least initially, to get that checked out. And there are ways for that to monitor that on an outpatient basis, to identify that before you would have to potentially experience a stroke. So
Okay, great. Thank you. Thank you very much. Were there any other questions from our audience here?
Someone is raising a hand, I think.
Oh, if you have a question, would you mind please using the question answer box and okay. So if there are any questions, we'll take them now. But I just, again, just wanted to thank you both for being here today. I know, sometimes with being on call for a stroke, with the stroke program can be a little dicey when you have a webinar like this. But you never know when a stroke may, someone come in with a stroke. But thank you very much for your time, Victoria and Dr. Adil. I really appreciate it. And I hope that our audience found it informative and useful. So if there aren't any other questions, we will say goodbye for now, and we will see you next time. And thank you again, and enjoy your day. Bye, everyone.
thank you.
Thank you, everyone.